Thanks for listening to the Pharmacy Podcast Network.
Currently, there are over 30 stimulant products on the market for ADHD. However, when it comes to non-stimulant options, the choice of therapy is very limited. For people with ADHD or parents caring for children with ADHD who want to avoid stimulants due to concerns of diversion, misuse, or side effects, this show will explain what other ADHD options are available and discuss data supporting optimizing its use. The views and opinions expressed on this podcast are solely those of Dr. Price. These views and opinions do not necessarily represent those of our sponsor. Dr. Price was not financially compensated by Supernus Pharmaceutical for his participation in this podcast.
Hey, what a special opportunity to dive into something that is really pertinent and timely. You know, we're headed into a new year. And when I think of this new year, I'm seeing so many roles of the pharmacists within pharmacies are changing. We see much more dive into conditions. We're talking about the network has pediatric focus podcasts where Dr. Jenna Quinn is really diving into specific situations that they've experienced, and they've taken a diagnosis and they've run with the treatment, and they've fed back the physician. So one of the subjects that keeps coming up, and there was an article out of the Syracuse University News, and this was published back in October of 2024. It says, what's driving the rise in ADHD diagnosis among children and adults? And this is a really interesting article. They go into some of the statistics and saying, according to a 2021 report, the Journal of Managed Care and Specialty Pharmacy, 8.7 million adults in the United States have ADHD. Now, as someone who experienced a lot of what was called back in my day, I went to Catholic school in grade school, and I was told by my teachers and my parents that I was hyperactive, and they didn't say ADHD in 1970. What was that, 8 or 79? But now we know what's going on. There's a lot more data. There's a lot more involvement. I want to welcome to this podcast a special opportunity to learn from Dr. Richard Price. It is so good to have you here, Richard, and I really appreciate you taking the time to talk with us.
Thank you so much for having me.
So give us some background with your research and your knowledge and the work that you're doing with Supernus, because we're very proud that they're helping us with this episode and bringing this information, helping us bring this information to the table. So talk to us about your background and what you've dug into with regards to ADHD, and especially in children.
Oh, sure. So I'm West Philadelphia born and raised. Went to college at Columbia and did my residency training in psychiatry at Yale. And I'm currently a professor of psychiatry at Weill Cornell Medical College in New York. And I have various practices throughout the state, federally funded and state funded, and supervised physician assistants and nurse practitioners. And I have a holistic approach to my practice, private practice as well in Muncie, New York. And I've been doing it for the past 20 years or so. And I see children, adolescents, adults, seniors, couples, pretty much for all conditions. So although ADHD is a large part of what I see, it's not the only thing that I see. And I think it's important to look at the whole person in front of you and not carve them up into various diagnoses, and try to match treatment to their entire profile. I got involved with Supernus because my son, he is a medical student and aspiring a psychiatrist as well. And we're always looking for research projects that we could do. And a few years ago, there was a new medication that came to the market called viloxazine ER, Qelbree. And we found that a lot of people were comparing it to an old medication called atomoxetine, Strattera. But we were seeing that it was quite different. And we conducted a study looking at patients who had taken Strattera and had then switched over to from atomoxetines to Qelbree. And we collected the data, real-world data, crossover studies, so each group was its own control. And we published that in CNS Drugs in July of 2023, not too long ago. And that paper went around the world as a landmark study highlighting some of the differences that Qelbree offers, the advantages and the tolerability and the efficacy above atomoxetine, which people never really appreciated. And through that, the makers of Qelbree, Supernus, discovered the paper, and they thought it was very worthwhile, and they're educating the community about the differences, which people hadn't appreciated before. So the study was entirely funded by us, no industry involvement there. But we just wanted to share the information so people could learn about new treatments that could change the paradigm and change the landscape in ADHD. I'm the son of a pharmacist, so it's very near and dear to my heart that I'm on a pharmacy podcast. And my mother was a nurse, so that's my background. And I grew up in the helping and healing professions. I'm also a rabbi, so I take a spiritual approach to things and look at lifestyle issues and non-pharmacologic interventions, which of course are always the first line in mental health before we jump to medications. So that's a little bit about my background.
I love this. So the reason why I'm so interested in this is we're seeing a surge in pharmacists becoming experts in a specific disease and managing the disease treatment. And within that scope, they're bringing in a holistic approach. They're bringing in spending time outside, breathing exercises, exercise, diet. They're bringing in dietitians. They're really thinking of the whole personalized person, and it's different for different people. So you were saying in the beginning of not carving up people into little blocks and treating everybody like some kind of big processing center, a conveyor belt where you're just kind of, hey, if you have ADHD, let's put you on this drug. Do you have ADHD? Yep, I do. Okay, let's put you on this drug. So slowing that down, that analysis of dialing into the patient specifically. Let's go to kids for a second. I was a hyperactive child. I remember getting in trouble because I couldn't concentrate. And there was no such thing as, at least in my neck of the woods in southwestern Pennsylvania, Butler, Pennsylvania, the community wasn't really into medications for kids in those days. We didn't really have a lot of medicated kids back in the mid 70s and 80s. And it was more of, they always said you were just a bad kid. You know, maybe you'd classify and be thrown into a corner of just being one of the bad kids. But now today, we know that we've evolved and we understand that there's elements of what's happening to that child, what's the surrounding of that child, what's the diet of that child, how much exercise are they getting, how much attention are they getting at home, are they even getting any attention at home? You know, are they just being given an iPad and expected to be raised in what's happening today? So start there about where you're seeing today rushing to either a medication or something, and we're not taking time sometimes with our children to really figure out what's going on in the first place.
Right. So we're becoming, in many ways, an ADHD society. And that is probably an evolution in human existence. And we'll see how it works out. You know, evolution sometimes works out well and sometimes doesn't work out. It's an experiment in some cases. So being an ADHD person who's highly functional might actually benefit you in certain contexts. Like if you need to be on watch and you need to notice things that are very salient in the background, and your attention is constantly switching. Don't forget, ADHD is really not an attention deficit. It's really an attention imbalance, meaning ADHD kids can hyper-focus, like on video games or things that pull them in. But if you think about like cell phones, for example, you're constantly bombarded with new and interesting information, certainly sitting kids in front of videos to placate them and keep them satisfied, or smartphones, just to keep them pacified. Then you go into a really boring classroom with a teacher standing in front and at a board or a screen, and the kids are checked out and then doing homework. And then even for adults who have to multitask, or for women who have to multitask at home and at work, having some level of ADHD actually might be required in our new society to be able to shift set, not get too stuck on one thing or the other, and keep moving in a fast-paced way. So I think we're breeding more ADHD, of course, through technology, certainly through our diets. Artificial colors have been examined right now. They might be pulled from the market. Thankfully, that's something I've noticed an association with. And then you ask the parents who may also have ADHD features to parent kids who have some ADHD features. Well, they don't have the time and the patience and the attention span to deal with it either. They're also on a hair trigger and a short fuse. So it'll be an interesting evolution to see if some measure of increased ADHD symptomatology actually ends up being necessary and functional in our society, or if it just completely leaves us dysfunctional. But right now, people are perhaps in some cases overusing some stimulant medications, which are pharmacologically similar to cocaine and methamphetamine, in order to enhance performance. And this is a dangerous, slippery slope that will we not even be able to function at the level that we have to without these chemicals? Is that where we're headed? Particularly, you see pressure in school for this. Pressure coming from the parents, pressure coming from the teachers, pressure coming from the therapists, that we need this kid medicated for chemical restraint, for optimal performance. What are we doing?
Yes. Yeah, I'm a dad. So I have 4 daughters and 4 drastically different personalities. And each of them have told me about aspects of nervousness or anxiety or something, and none of it, thank goodness at this point in my life, has been extreme, but it's definitely impacted speech, where one of my daughters wasn't able to communicate with her teachers because of nervousness, would shut down, and they called it selective mutism. And shout out to the school. They did an amazing job helping to condition her and pull her out of that. We got her into plays, and now she's addicted to plays, and she's a chatterbox, and she's opening up, and she's do. Well, that was an element of anxiety that we're noticing and paying much more attention today, which is the good side of evolution of medicine, than what you and I grew up in. When we were younger, when I was younger, I know in the 70s, it was just you're a bad kid, and or you're dumb because you haven't paid enough attention to the material because you couldn't even sit still. And now at least we're at least we're flagging kids with these issues. But to your point, when do people like you and I, who experienced a different way of life and culture, we're going to all die out? And then the generations after us, are you saying that we're going to evolve into just becoming an ADHD, as we'll just become part of humanity in our evolution?
Well, we'll see where it goes. I mean, there's some benefits to ADHD in terms of the creativity side.
Yeah.
Many kids and adults who have ADHD are the most highly creative and funny and spontaneous people. And if they're on the wrong treatment, while they may be more focused and behaved, they can feel like they've lost their personality, they lost their juice, they lost their creativity. So you could think of it, like I said, an inverted U-shaped curve, where, if you're completely highly symptomatic, you're completely dysfunctional. And then as you sort of turn the dial, let's say up on the treatment, and you get more and more focused in, if you overturn it, you can get more depressed, you can get more hyper-focused, you can get more irritable and agitated and even psychotic. So, there's a balance here between intervening, not intervening, intervening with the most favorable treatments that address the whole person and not just having someone medicated and restrained. So it's a balance, like, most things in life, it's not all good or all bad. It's not like anti-meds or pro-meds. It's not like we should diagnose or we shouldn't diagnose. We wanted people to be doing as well as they can do while still appreciating the way they were made and the talents and the abilities that they have that were, naturally innate within them, and developing them. So getting kids into something that they really enjoy, maybe it's Taekwondo, maybe it's art, maybe it's music, could help them develop their brains into a more focused way for other things that they may not have ever been more interested in. Because if you can get out of that window, that critical period where all the synaptic pruning happens, the pruning of the bushes of the tree, so you can get those nice tracks and developmental nourishment to kind of, nourish the brain into its more final form, its solidified form. That might be able to be accomplished just by tapping into some of the innate strengths of every unique child. And that's going to involve a paradigm shift in our educational system. Not every kid can just participate in frontal learning with one teacher and 30 kids or 40 kids in a room. They need smaller class sizes, different types of learning, like Gardner's multiple intelligences. We need all these types of people in our society, not just those who are masters of reading, writing, and math. They should be competent, but they have other things to offer us that will move society forward. And we don't want to squash that or just favor one type of intelligence over another.
Absolutely. So the pandemic was a horrible time in our modern history, and it was so recent that everyone that's in business and in the business of healthcare and in pharmacy remembers exactly how it impacted our nation. That also threw us into a laboratory-like environment where we had our kids at home. Some of them weren't going to school, so they were there. And it did give a lot of feedback and time for us to dial into the way that our children were feeling. And I asked to this day, all four of my daughters, two of them were still in grade school at that time, what that experience was like. And this paper that we referenced as we got started says that the pandemic helped us to really hyper focus into some of our children's issues because we had much more time with them. And there was good that came out of it because there was also bonding between parents and children in ways that there wasn't. And it also poured back into the pediatrics and psychiatry side. We're really dialing into the data that's coming out of to a lot of these studies. And now we're post-pandemic and we're moving forward. This is a new year. So this is a special time for pharmacists who are out there who are really interested in the psychology side of the pharmacological world and working with psychiatrists and working with specialists. There are so many out there that arise out of our health systems, but they also are looking to do more private practice consulting as well. And shout out to Jenna Quinn, who's doing exactly that. What is some of the go forward from the data that you have? You think we should start with children and adults because you're helping and referencing adult studies too? Where do we go now that we have so much more data, we have more information, we have better technologies, definitely better medications? What's next? Should we start moving to pharmacogenomics first, or start to test and start to build a hyper-focused way of treatment quicker and faster than sometimes it's taken? In my case, back in the 70s, didn't even get time to diagnose it, right? Well, now look how far we've come. So what, in your opinion, what's next?
So I think what's next is looking at preventative strategies, because right now I think people are running for the medications, for the quick fix, and they're not necessarily considering the long-term consequences of that, both psychologically and chemically. So if we have to use medications, I prefer the non-stimulants rather than things, like I said, that are derivatives of cocaine and methamphetamine. But I think that we should evolve our educational systems, our parenting, coaching, and our professional interactions with kids to try to explore and fully exhaust all the non-pharmacologic agents and interventions and even natural things, lifestyle things, enrichment things before we jump to medication. So it's wonderful when that comes from a pharmacist, because people are so taken aback when it comes from a physician like myself. Like, wow, a doctor would recommend something other than medications? Yes, and it resonates so powerfully because it came from a medical professional. It was a prescription for health. It wasn't just a prescription for meds.
Right. That's awesome. That's great. And that's where we're moving. That's where we see pharmacy moving. There's a lot of worry in our profession right now. We have a collapse of the fast food pharmacy market where over 7,000 pharmacies have closed throughout the United States within the last 4 years. We're now seeing cracks in the realm of education. Of the 142 pharmacy schools, one has closed in West Virginia. It's a it's a time to see that the evolution of pharmacy is, I mean, it's changing. And the role of the pharmacist is changing. If there were more pharmacists that were being paid to dial into a specific theme, let's say in mental health, for goodness sakes, because we need that more than ever, really. I know it, you know it. So now we have pharmacists who could concentrate on taking groups of adults, or groups of athletes, or groups of women, groups of men, groups of children, groups of, so many subsets of geriatrics and people over 65. Each of those demographic sectors of human beings are different, and you could really, as a pharmacist, dial into each of them. And that's why I'm a glass half full kind of attitude guy, because I see a future of pharmacy going to be much different than what I grew up in 70s, 80s, 90s. And now it's an opportunity. So people like you get me excited because you're bringing a lot of that data to the table. So this is why we've appreciated this conversation with you, Richard.
Well, in many ways, it's almost like going back to the past, because my father would tell me stories where he had a very close relationship, with his, whatever you want to call it, can't call his patients, maybe his clients, his customers, whatever you want to call it. And, he would deliver things to their homes. He would see them in their homes back in the old days. He would compound medication. He would, there was even like herbal remedies back then that people were taking, or supplements or things, and they were quite knowledgeable. There was a class called pharmacognosy, which was not, necessarily medications that were, FDA approved typical medications, but they were interventions that pharmacists would do back at the old apothecary. That's what it was called. And they had more of a holistic bent back in those days, probably because there were fewer medication options, but people were still plugged in then to things that weren't necessarily medications per se, but were still interventions that pharmacists were quite schooled in then.
Yeah, I think of life expectancy over the last, say, 25 years, right? And I wonder, evolution of medication, obviously vaccines, goodness gracious, and saving millions and billions of people's lives based on things like polio, for example. So modern medicine is just freaking amazing. I read about what you are doing specifically, and what our pharmacists are doing, and it blows my mind. However, I almost think that there's this strange balance between coming from the dark ages and not having any medication dial-in abilities to save people's lives. But then all of a sudden, when does the needle go the opposite way, where you're like, wait a second, now, so we have to look at life expectancy. Life expectancy for a 25-year-old in the United States is 52.4 years. For men, 56.9 years for women. However, life expectancy in the U.S. has been declining. So they're saying that added on to 25 years. So, I mean, that sounds pretty good to me. I mean, you're getting into your 90s. And I remember, both of my grandmothers, my one grandmother's 98. She's still living. And my other grandma died at 95. So I think my personal chances from a genetic perspective is good. But talk to us about life expectancy and longevity, but better yet, living good lives, not being in a wheelchair, or being, because you didn't take care of yourself, or because you allowed, diabetes to run off. But talk to us about that, the quality of life and life expectancy and journey.
Yeah, so we have to think about some things which are very obvious that minimize life expectancy, and that's violence and fentanyl overdoses, and things that are really entirely preventable, societal issues that take young people way too young who were otherwise fairly healthy. Nutrition, we're not doing well on the nutritional front compared to some other, let's say, less quote unquote advanced countries that don't have the most modern medicines. We're not doing so well on that. Sleep, exercise, stress management, even just living a life of meaning and purpose, perhaps spirituality, can have longevity impact. And also end of life care. So let's say a person is living to 90, what is their quality of life, let's say from 80 to 90? Are they on a ventilator for many years? Are they having ulcers and bed sores, and we're prolonging their life as much as we can to get a higher number and more years? Is their quality of life at that point? So these are all factors that go into that overall number of life expectancy. Of course, COVID took a hit in that, but we're recovering from that. And are we playing around with viruses, in terms of gain of function and making super viruses that we can't keep up with? These are things that we can do, not to beat death, and it's inevitable, but to live better lives. And we need to get our priorities straight in terms of what's important and how far science should go and where science should not go. And I think it has mental health implications because while it's these smartphones and technology and AI has great potential, it also is creating a lot of stress and a lot of disruption in our circadian rhythms, in our hormones, and in our life expectancy. It's perhaps making certain things easier, but we're not adapting as humans fast enough as the technology evolves. And these are just things we have to consider as we bring in new technology. And as we regulate it, or we try to regulate it, which we're not really regulating it. We're just like, oh, it's new, keep going. Yeah, but at what cost? So it's like you're spitting in the wind. You have a lot of these systemic factors going against some really excellent medications that are more effective, better tolerability. But then what are we doing overall for the picture? And as the doctor-patient encounters become shorter and shorter and shorter, with managed care pressures, that opens up a portal for perhaps pharmacists and other specialists who may feel they have additional time to spend with the patient. Because it used to be when someone called my father and say, "What do you think about this medication?" He goes, like, "Ask your doctor. Ask your doctor." I'm like, "Your doctor? Ask your doctor." And then the doctor would be responsible. I'm certainly responsive. People text me all day and all night, and I give them advice all day long. So I'm responsive. When the pharmacist is dispensing medical advice and not consulting with the physician, we want to work together. We don't want one undermining the other. So if someone gives a piece of medical advice out of context as a pharmacist and say, but they don't know your case. They don't know your situation. I'm not prescribing it for that. I'm prescribing it for another reason that's not listed in the book. Oh, I didn't know that. So now you have to call the pharmacist and say, why did you tell my patient this? We want to work together because we all want the benefit of the patient.
Yes, that's where the electronic health record outreach and interconnections are coming in, where pharmacists are now able to communicate back to a physician in notes in saying, hey, here's a suggestion, or here's something that's going to happen from this dosing, or hey, could I run a PGX test because we keep missing the right medication, whatever it is. It's that opportunity to communicate, document, communicate, adjust, and is where that pharmacist can become that right hand of the quarterback of the case for the patient, and mental health specifically, because of making slight adjustments in suggestions of what they could do to help an individual. So the personalization of medicine is exciting because I do see things changing, and certainly I'm impatient. I'd like to see it happen faster, but it is. I do see it changing, and I see it getting better. We are dialing into individual people's needs, and we're seeing that pharmacists are having an opportunity to participate in that. So this has been a wonderful conversation, Richard. Is there any reference of data, reporting, or anything else that you can give a shout out to of where pharmacists that are interested in ADHD medications, helping their patients, and doing maybe more for their patients than what they're doing?
Well, just as a selfish plug, but I don't think it's a selfish plug. I think it really is a good article. So it's extended release viloxazine compared with atomoxetine for attention deficit hyperactivity disorder. Lead author is Maxwell Zachary Price. I'm the second author, Richard Lewis Price. It was published July 2023 in CNS Drugs. And what we do there is we look at the entire landscape. But like if you have a patient come in and they're like predominantly ADD, they just inattentive just for like a few hours a day for some high needs of a school or for work or whatever, and they have no comorbidities whatsoever. So perhaps a stimulant is appropriate. I would use methylphenidate before I would use amphetamine. Amphetamine is more powerful, more side effects. Okay, but then more often than not, you have what's called comorbidities. You have ADHD that lasts the entire day. It affects your self-esteem. It affects your mood. It affects anxiety. It affects your executive functioning. You need something that's going to cover you morning, noon, and night. So if it's predominantly hyperactive and impulsive, so the alpha-2 agonist, the guanfacine extended release, the clonidine extended release, there's now a liquid clonidine now called Onida, very helpful for people who need to titrate doses and for kids. Perhaps that's the best choice. But then you have something new. You have haloxazine ER. You have Qelbree, right? So everybody thinks Qelbree is the same as Strattera. It's not. That's what our study looked at. So with Strattera, it's more rapidly acting than Strattera. It's more effective than Strattera. It's better tolerated than Strattera. It doesn't have the same metabolism as Strattera in terms of adjusting doses. It's just an entirely different mechanism. It's not just a norepinephrine reuptake inhibitor. It's a mild one, unlike Strattera. It also works not as an SSRI. Everybody thinks it's not an SSRI, and it's not a dopamine reuptake inhibitor. It's 5-HT2B, 5-HT7 antagonist, and a partial agonist at 5-HT2C. Now, that may sound like gibberish, but the net result is you are increasing prefrontal cortex, dopamine, norepinephrine, and serotonin without being a reuptake inhibitor of serotonin or dopamine. That's an entirely different mechanism. So where does Qelbree find a role? For those who need focus, but they don't want a stimulant. Stimulants have side effects, appetite suppression, tics, anxiety, wear off, insomnia. These are very common comorbidities that patients may have anyway. We don't want to exacerbate that. Well, stimulants are the gold standard. Well, maybe they're not the gold standard for every patient. Maybe as we involve new treatments, we have to revise our algorithm. This is what the clinical experience will teach you that you won't get in the books. But by publishing this, it gets in the books. And now people who like to reference data can put this into their clinical experience. So where Qelbree distinguishes itself, people have comorbid anxiety, comorbid depression. Qelbree was an antidepressant in Europe for 30 years as an immediate release, viloxazine IR, brought to this country, made into an extended release called Qelbree, not bioequivalent. So it helps depression, helps anxiety, helps the full spectrum of ADHD, the inattentive, the hyperactive, the impulsive, rapidly acting, FDA approved for kids, FDA approved for adults, helps kids sleep at night, it's given for adults in the morning, helps them with wakefulness. So these are things that this article explores in a controlled study type of way that I think is landmark because people don't know what Qelbree is. And I'm not promoting Qelbree. I'm just promoting doing right by your patient and not just going to treatment guidelines and algorithms, one size fits all approach. So I invite people to learn more about where Qelbree fits in the algorithm, the new algorithm, I would say, of treating your patient. And that's one resource. But I also invite people to check out the Supernus website because we're going to be doing webinars throughout the country through different time zones where I believe clinicians of all kinds can log in and learn more about ADHD disease state and also Qelbree and have hopefully an interactive, rich discussion where they can write in questions and I can get to meet the people who are listening to this podcast because this needs to go far and wide, not just to clinicians, to parents want to learn more and adolescents and adults want to learn more about what ADHD is, what it isn't, and how to get guided toward the best treatment that meets their needs and not just looking at numbers and effect size and algorithms. ADHD, you could say, has comorbidities, or you could say that the comorbidities are so common that these are part and parcel of the ADHD itself.
Dr. Price, we're going to have links inside the show notes of this podcast episode. If you're driving, if you're jogging, if you are just listening right now, there's no problem whatsoever. Take your time, get back to somewhere safe. If you are, where you can go to a website, Supernus Publications is where this is at. And you start off at the homepage, which is Supernus or SUPN publications.supernus.com. We will have, once again, links in our show notes to take you to this website, these references and the publication search directories that they have. And then also, we're going to put a link into the show note that you said, Richard, in your article that you've published, because we want our pharmacists to have access to that too. Hope you'll come back. We'd like to have some pharmacists on with you that do specialize in mental health and dialing down into even ADHD and have an additional discussion. We'd like to talk to you again in the geriatrics forum and really talk about the population that's going to be one of our most important demographics and the attention that pharmacists and physicians are on for the next 25 to 30 years. And then, of course, I'll be old by then too. So please, I want to be better taken care of in those days. But Richard, this has been wonderful. Thanks for doing this and being our guest today.
Thank you so much. Be well.